Assalamu alaikum everyone and good afternoon. I'm Dr. Farooq Rathore, consultant in rehabilitation medicine, and now I'm going to describe the different rehabilitation perspective in multiple sclerosis, and I'm going to highlight how involving a dedicated multidisciplinary team of rehabilitation professionals can make a positive difference in the lives of people with multiple sclerosis. There are no disclosures and conflict of interest related to this particular presentation. We do not have data available from most of the developing countries, including Pakistan, but it has been estimated that multiple sclerosis is the most common cause of non-traumatic neurological disability in young adults in the Western Hemisphere. And the most important thing to understand in rehabilitation perspective is that while the medical management of multiple sclerosis is almost the same across all age groups and probably with people with different backgrounds, but the impact of disability is different in different people. For example, a housewife with multiple sclerosis is going to have a different form of disease as compared to, let's say, an elite athlete, or maybe compared with a professional or a banker, or maybe to a school teacher. So all of them would have the same diagnosis of multiple sclerosis, but the impact of disability in their lives is going to be different. And that is what makes rehabilitation medicine interventions a different sort of thing. The first question is, so what is multiple sclerosis rehabilitation? And one of the definition that I like is that rehabilitation in multiple sclerosis is considered as a process that helps a person achieve and maintain maximal physical, psychological, social, and vocational potential and quality of life, which is consistent with physiological impairment, environment, and life goals. So if you pause for a moment and reread this definition again, it would tell you that unlike other things and other medical intervention, which are sometimes a one-time event, you give a patient a prescription, you give them an injection, you give them a drug, and you simply send them back home, right? But rehabilitation is actually a process. It's an ongoing conversation between the patient, the family, and the caregiver, and the rehabilitation professional. And it is something very fluid. It is something very dynamic, which can actually change on every visit. So you can't have a set template for multiple sclerosis rehabilitation for every patient that comes to your clinic. You have to make it tailor-made to the needs of the patient. And sometimes the patient might be having more physical need than the psychological needs. But in some cases, their social issues and vocational issues are their topmost priority, and you have to address them. And this is what makes multiple sclerosis rehabilitation a little bit different from the routine traditional medical management. The most important thing to understand is that rehabilitation is not a solo flight. So a simple having a rehabilitation medicine consultation would not mean much to a patient with multiple sclerosis. You have to involve a team of different rehabilitation professionals, which is known as multidisciplinary or interdisciplinary rehabilitation. And the important team members may include number one, a rehabilitation medicine physician, then physical therapist who would direct all the exercise programs, specifically of the lower limb and gait training, then occupational therapists who are experts in upper limb dysfunction and energy conservation techniques. Apart from that, if the patient needs some kind of orthosis or supports, orthotist is the one who are going to guide and help them out. And obviously, multiple sclerosis carries a lot of psychological burden, which many a time cannot just be managed with giving them antidepressant and antipsychotics. You have to involve a clinical psychologist, which is a very important team member of a standard rehabilitation team. And the most important member of this team is actually the patient and family. And you have to consult them again and again, because please remember, rehabilitation is a process, it's not a one-time thing. Apart from that, if the patient has to be admitted in the ward for medical condition or deterioration of physical impairments, then there's a role for rehabilitation nurse and in some cases a speech therapist as well. Now the question is, so what is the advantages of having a multidisciplinary or interdisciplinary rehabilitation team instead of having, let's say, only a physiotherapist or OT or only a rehabilitation medicine doctor? So the advantages are, number one, if you integrate an interdisciplinary rehabilitation model, it would allow a comprehensive evaluation and problem identification of the patient and the family. Number one, there will be common goal settings. So instead of the patient going to different rehabilitation professionals in different time and everyone having a different understanding of their problem, when all team members, they sit down together on the table and then they have a common goal setting, the ultimate beneficiary of this approach is the patient and the family. Then there are multiple inputs from different professionals and pooling of knowledge. So there's a possibility that one of the professional knows about a particular thing much more better than other person. and when they pool the knowledge, the ultimate advantage goes to the patient and the family. And it also results in a better follow-up and long-term planning for the patient. So these are the advantages of having an interdisciplinary or multidisciplinary multiple sclerosis rehabilitation team. There are different models of service delivery in MS rehabilitation, and the most common are four. It can be provided as inpatient rehabilitation, at least in the acute phase, or when the patient comes to the hospital in a poor condition, they cannot walk, they cannot manage themselves. Then once the patient is much better, you can discharge them home and they can visit you at as an outpatient in the outpatient rehabilitation department. Then there is some home-based rehabilitation as well. And in the last couple of years, now tele-rehabilitation is now playing a very important role in providing rehabilitation services, not only to MS, but also to other people having chronic neurological and orthopedic disability. The situation in Pakistan is that right now mostly we offer MS rehabilitation only in two models. Number one, outpatient rehabilitation, in which our colleagues in neurology, they refer patient to us, or usually the patient come to us directly. We give them a plan. We have a team meeting if our team members are available, and we give them an outpatient rehabilitation plan in which they have to visit the department twice a week or thrice a week, or depending on their disability, sometimes even daily for a couple of days. But the important thing to understand is that you cannot provide rehabilitation to a patient lifelong in hospitals. They have to go back to life. They have to go back to their homes. So in that case, most of the time, if the attendants or caregivers are learned, you can actually teach them how to provide these services at home, and probably they can continue the same services at home. If that's not the possibility, in Pakistan, our colleagues in physical therapy and other rehabilitation professionals are available for home visits, and they do that. Now, what are the different MS symptoms in which rehabilitation can be helpful? It's a long list, and obviously I'm not going to go in detail of everyone, but just to give you an overview that how rehabilitation can improve the quality of life, mobility, and integration of these people into community. So rehabilitation helps with reducing the fatigue, spasticity, it helps in pain management, bladder and bowel issues, mobility issues and gait dysfunction, swallowing problems, speech disorders, cognitive dysfunction, and also depression, which is a part of many neurological illnesses. So I'm going to cover a few of these aspects, and I do hope that it gives you a lot of food for thought, and probably then you can connect with me by emailing me or exploring it on your own in the biomedical literature. So how to do multiple sclerosis rehabilitation? You need to understand simple things matter most. Sometimes it is the simple things that can make a lot of positive difference in patient's life, and I'm only going to explain these points. The principles are: number one, please start early. So if you are a neurologist or you're a medical specialist who has a patient with multiple sclerosis, I would request you not to wait till the disability takes over. And now the patient is having a severe grade 3 spasticity, or maybe severe bladder dysfunction, or severe neuropathic pain, or he or she is unable to ambulate or move around in the community. Please start early. A multidisciplinary team approach is always better than having only a referral for physiotherapy. Physiotherapy and exercises are absolutely important and integral part of the MS rehabilitation, but please remember they're only one part. So you cannot say that the patient is getting rehabilitation if the only thing he or she is getting a physiotherapy referral and only exercises and physical therapy. So please go beyond that. Then the rehabilitation has to be patient-centered, and the goal setting must be done in consultation with the patient and the caregivers and the attendants. And please remember, every patient has a different background and they might have different goals, they might have different dreams. And it is important for the rehabilitation professionals to help patient achieve most of those dreams as much as possible. Then there must be a mechanism for regular follow-up for the patient. And please remember, the rehabilitation follow-ups are not for days or weeks. Sometimes they go on for years and decades. It's a lifelong commitment with the patient. Then you have to involve your clinical psychologist in the counseling so that the patient can understand better what kind of disease they're having, it is progressive or non-progressive, and what kind of impact they're going to have later on in life. And then you have to discuss the outcome, because the outcomes are not going to be the same in every patient, even if you provide them with best of the medical care in the acute phase. And then you have to discuss the prognosis, and many a time these things of counseling, prognosis and outcome is actually left to the rehabilitation team, and this is one of the things that we do regularly. Now, coming to the individual symptom, for example, the first of all and the most common is fatigue, and it has been documented as one of the most common and troubling symptom for the patient with multiple sclerosis. Now, fatigue and cognitive dysfunction are usually one of the major contributors for which people sometimes have to leave their jobs. So they can't concentrate on their job because of cognitive dysfunction, and they cannot function properly, they cannot travel, and they cannot use public transport because of the fatigue related to multiple sclerosis. So it's important to manage fatigue related to MS. And the important thing to understand again is, I would like to re-emphasize that treating fatigue with an interdisciplinary approach instead of only giving medication will not only improve the fatigue itself, but would also enhance the overall performance of the patient with multiple sclerosis, both in their community, society, and daily lives. And you also need to understand that what is the main cause of fatigue. It could be multifactorial. For example, the fatigue might be secondary due to the disease process itself, which is leading to demyelination, or it could be the effect of medication that the patient is having. It could be because of post-disease depression. It could be because of heat, which is a very important consideration in a country like Pakistan, because not all of your patients will be having access to 24/7 temperature controlled environments. And there's a major issue with these patients, at least in developing countries and country with hot and humid climate like Pakistan. Then this fatigue may be secondary to different kind of neuropathic pains, infections that the patient might have, sleep deprivation, the patient cannot sleep well at night, and this translates into a chronic long-term daytime fatigue and somnolence for the patient, and obviously stress related to the disease. So first of all, please identify the main mechanism behind fatigue. And sometimes only by adjusting the activity schedule as to avoid the overheating and cooling techniques can actually reduce the fatigue by 20 to 30%. So even before you start off with medication, you can actually do certain things which can actually help the patient reduce the fatigue and improve their mobility. So for example, you can do some certain kind of home and work environment modification, maybe more cooling, maybe more air conditioning, asking the patient to take a lot of cold fluids, and probably encouraging them to do work from home instead of commuting daily in a hot, humid climate. Then obviously, yes, exercise do have a role, but please understand, in a patient with fatigue, you have to do some certain kind of graded exercises, which means you go step by step. So you don't start with strengthening exercises on day one. Probably you simply start with gentle range of motion, you start with gentle cardiovascular exercises, you simply start with gentle stretching exercises, and probably in the next step you start with the strengthening exercises. And you have to give a time for cool down period as well in between the sets. Yes, medication do have a role, and our colleagues do use a lot of medication, and sometimes they do help with fatigue, and the options include amantadine, modafinil, and methylphenidate. The next symptom that is very problematic for the patient with MS is spasticity, which is defined as an increase in tone in response to movement. The first thing is you need to identify the inciting agent. So please remember, for example, it might be an ingrown toenail at the in the toes. It might be a carbuncle. It might be a UTI, which is not being identified, and it is leading to a vicious cycle in which the spasticity is increasing day by day and not even responding to physical therapy and medication. So first of all, identify the inciting agent. Then yes, there are many options for pharmacological agents like baclofen, tizanidine, diazepam, gabapentin, and perisone in Pakistan, and you can have a mix and match of different kind of things. But you need to understand, if the patient is active and already having a cognitive dysfunction, you might want to avoid drugs like diazepam and tizanidine, which can cause sort of sedation and drowsiness. Then yes, the mainstay of management of spasticity, the non-pharmacological management, is exercises. And nobody can do it better than a physiotherapist or physical therapist, and they would include regular passive stretching exercises, positioning, which would help majority of the patient. Orthotic can also help, and when it comes to injections, please remember, botulinum toxin is widely used and recommended and supported. I also support that. But in a country like Pakistan, you have to give other options as well. Not all of your patients are going to afford that 22,000 rupees botulinum toxin injection that you have sometime to give twice a year. People would not come back to you. So please do explore a phenol block, and rehabilitation medicine physician, at least in Pakistan, are well versed and trained in the use of phenol block, which is pretty low cost as compared to botulinum toxin and works very well. Balance and gait dysfunction leads to fall, which can actually lead to fracture and other issues. It also lead to reduced community ambulation. It can also lead to isolation and can also lead to loss of employment. It's a very important thing that cannot be managed only by medical management and giving them lot of medicine. First of all, again, address the cause. It might be because of medication. The patient is taking some antidepressant medication or medication for sleep, and that's causing the balance and gait dysfunction. Or it might be true weakness because of the disease process. or it actually might be increase in the spasticity that is causing difficulty in ambulation. So first of all, please do a comprehensive evaluation, and nobody can do a better evaluation than a interdisciplinary team in which different professionals like a physical therapist, OT, and rehabilitation medicine physician, they all come together. Pharmacological agents have a very limited role in improving the balance and gait dysfunction, so please focus more on the non-pharmacological management instead of giving them medication. But yes, for example, if the issue is with spasticity, you have to give them some kind of medication. So you can probably employ techniques like lower limb strengthening exercises, focusing on the quadricep and hamstrings. Then you can do the Frankel coordination exercises and graded gait training, which can be done in parallel bars, without parallel bars, with the help of gait aids, and without the help of gait aids. And maintaining postural control while walking is also very important. And there are certain other exercises that have been explored. They are easy to do, they don't cost much, and you can actually see the videos on YouTube, and you can integrate them in your patient's life. And they include the traditional Tai Chi exercises, different yoga exercises, aquatic exercises, and Fendel Grace kind of exercises. So there's absolutely no harm in trying these exercises out, because they are useful, they don't cause much, they don't cost anything, and they are innovative. Apart from them, some people they deteriorate even if you offer them a good exercise plan, and then they have to be provided with certain assistive devices. And again, as I said earlier, please start early instead of being late. So probably you can start with simple canes, forearm crutches, and walking frames. But again, let me re-emphasize this point, that it is a rehabilitation professional who is going to guide the patient in a much better way, that what kind of assistive device they require at what kind of time, and how to ensure that the assistive device is a good fit and the assistive device is of a right size and fit for the patient. So that's why another reason that you need to involve a rehabilitation medicine professional. Then sometimes you have to use lower limb orthotics for the management of weakness, foot drop, or spasticity. And the most common is actually a polypropylene ankle foot orthosis. And alhamdulillah, this is available, and custom made AFOs are being made in almost all major cities of Pakistan. They cost somewhere between 3,000 to 7,000 depending on the material used. But again, it is easily available all across Pakistan. If you want to do something different and the patient wants to go one step further, you might want to import a peroneal nerve stimulator, and that can also help in regaining a normal and natural gait balance. But again, it would cost a little bit more, and also although it can be ordered from any good website, medical website abroad, but it needs a little bit of learning curve, and you have to follow up the patient for a little bit more of time. Pain is one of the neglected symptoms in multiple sclerosis, and although Charcot described pain in multiple sclerosis as early as 1872, but many a time this symptom is neglected in patients with multiple sclerosis, and the focus goes on other aspects. We need to understand that research shows that untreated pain, significantly impairs the quality of life in around 45 to 65% of multiple sclerosis patients. It's a huge burden of disability that needs to be met. And the most important thing here is actually that rehabilitation medicine physicians are formally trained in pain management. If you go to the USA, there are only two specialties who are authorized to do a fellowship in pain medicine or pain management, either an anesthetist or a rehabilitation medicine professionals. We are formally trained in the principles of pain management. Many of us do high quality interventional pain management as well. So probably sending your patient to a rehabilitation medicine professionals is not only going to improve their disability, it's also going to improve their pain management protocols. The pain could be multifactorial, could be related to the disease itself, which is a demyelinating disease and causing neuropathic pain, or it could be a consequence of the disease because of repeated falls, because of spasticity and other things. And it could have a neuropathic and musculoskeletal component both. So you need to identify which component is bothering the patient at that particular time. Yes, the pain management would include certain kind of medication, but do not only focus on NSAIDs, because this pain is of a different variety or a quality. It has both a neuropathic and musculoskeletal component. So you might want to use NSAIDs. Yes, different kind of NSAIDs available over there, but you might want to use muscle relaxants as well. And probably it's a good idea not to use sedative muscle relaxant like tizanidine. And you might want to explore like eparisone or maybe thiocolchicoside and stuff like that. And then you can also use specific neuropathic pain medication like pregabalin, gabapentin, and the latest one like lacosamide. And antidepressant do have a role in the management of chronic neuropathic pain and chronic musculoskeletal pain as well. And probably you might want to explore duloxetine and maybe fluoxetine low dose and even escitalopram. Physical modalities like the use of TENS, transcutaneous electric nerve stimulation, diathermy, ultrasound, they are safe in good hands and they do help a subset of patients. So please do explore these physical modalities. Exercise and mobility training sometimes releases the endogenous pain relieving hormones and the patient feels really good, and you can actually have better pain management in these kind of patients. Bladder is also a very problematic issue with this kind of patient, and because multiple sclerosis is primarily an upper motor neuron type lesion. So these patients sometimes develop hyperactive bladder and they have issues with controlling their bladder, and their clothes get wet, and that's a major issue for many of these patients. So you can actually this bladder irritation and frequent voiding of small volume of urine and fear of incontinence is bothersome for most of the patient. So the most important step in assessment is, first of all, you do a PVR, urine volume, post void residual volume, that after the patient voids, how much volume is left behind. And then you can probably start with a fluid restriction, that is a non-pharmacological mean of management. And then yes, you can use anticholinergic medication like oxybutynin or toltorridine. So the summary and the take-home message of this presentation is that, number one, multiple sclerosis rehabilitation is an important and integral component of a comprehensive multiple sclerosis management plan. Please remember, you cannot send your patient back home with medication alone and ask them to follow up after 1 month or 3 months, considering that you have provided all what was needed. No, they need integrated multiple sclerosis rehabilitation intervention. Number two, wherever possible, please make a referral to the rehabilitation medicine professional or a rehabilitation medicine physician for disability assessment and rehab plan. It has to go beyond physiotherapy because it is an interdisciplinary team approach which requires input of different professionals like a rehabilitation medicine physician, physical therapist, occupational therapist, clinical psychologist, and orthotist. So please go beyond only from prescribing physiotherapy and exercises, and probably then you can make a positive difference in these patients' life. So I will end my talk on this. A proactive rehabilitation approach to maximize function, relationships, and employment opportunities can lead to a higher quality of life for all patients, even those who have worsening multiple sclerosis. I thank you all, and if there are any questions, I'll be happy to answer. If you need a copy of the presentation and other different resources on multiple sclerosis rehabilitation, please feel free to email me at this address. Thank you very much. And thank you, Dr. Wase and Department of Neurology, Aga Khan University, Karachi, for giving me this opportunity to share my views. Thank you again. Assalamu alaikum.